All right, let's start. Bismillah. Okay, assalamu alaikum. My name is Khalid Alnajjar. I will be your tutor for this session today, inshallah, which will be talking about the basis of hemostasis and thrombosis. Before I start, I just want you to note that down here is my contact information, my email and my phone number. If you want to ask me any question, never hesitate to ask me any. I'll be more than happy to help regarding this lecture, HLS generally, or any other block you want. Again, I'll be more than happy to help. Before I start, I want to give you an overview about what this lecture is about. It's basis of hemostasis and thrombosis. What is hemostasis? Hemostasis is basically controlling the bleeding from blood vessels in the body. Okay, and thrombosis is the process of forming thrombus or clots. I'll be digging deeper into this inshallah throughout the session. But generally, quick overview, hemostasis has three primary processes. These are the learning objectives. Okay, let's start by talking about normal hemostasis, and then we can talk about what can go wrong with hemostasis. So normal hemostasis has, let me say, as I said, three different processes, and also three different factors that are mainly affecting the hemostasis. The first one is the integrity of the blood vessel. One sec. Yeah. So integrity of the blood vessel is the blood vessel. So this is the blood vessel, as you know. When I say integrity of blood vessel, I mean how rigid the blood vessel itself is. I don't want the blood vessel to be injured. I want it to be open. That's when bleeding will happen. Okay, if this blood vessel, if there's an injury, if there's a trauma, or for any reason this blood vessel ruptured, then that's when we can say that there is no more integrity of the blood vessel. Okay, normal platelet count and function, as you might know by now throughout your studying of HLS. Platelets are the blood cells that control bleeding and so on. So if you have abnormal function of the platelets, or you have deficiency in the platelets, you won't have control of bleeding or hemostasis properly. Normal levels and function of coagulation proteins. There's something called the coagulation cascade. I'll be talking about in details in the couple of slides coming. But this is basically a cascade or a process in which coagulation or thrombus or a clot forms. Okay, now this brings me to something. I don't know, if I asked someone, do you think forming clot is good or bad, or is it healthy or unhealthy for someone, for a body to form? He'd directly say, no, I don't want clots in my body. But no, on the other hand, forming clots and thrombosis is a process that is going on in your body as we are talking right now, as I'm explaining right now, as you are studying right now, because there are minor bleedings here and there in your vasculature in your body, and you don't want that to grow, or you don't want that minor bleeding to be big and become a major bleeding. That's the big issue about hemostasis or about bleeding generally. So you want coagulation, and you want your body to form those clots through thrombosis to prevent those minor bleedings from minor blood vessels or for any other reason. Or also another huge example is during trauma and injuries. Anyone, la samahullah, got through an accident, a trauma, or an injury for any reason, their blood will start bleeding. Okay, or when you cut your hand, when you cut your skin, you will start bleeding. So for your body to stop this bleeding, your body has to form a clot or a thrombus, and now I'll explain the difference between a clot and thrombus in order to stop this bleeding, regardless of how big or small it is. Okay. Type. I said hemostasis, or the controlling of bleeding, has three processes or three different. Okay, it's a process with three steps, mainly, or four steps. Sorry. So the first one is vasoconstriction. The second one is primary hemostasis. Then we have secondary hemostasis, and then we have thrombus and antithrombotic events. Okay. So I want you to imagine with me, if you had a paper cut, for example, okay, what is the first thing? You have a paper cut, you started bleeding. The first reaction or the first reflex your body has is to vasoconstrict the blood vessel that is injured or the blood vessel that is ruptured, okay? if your body controlled or if your body constricted this blood vessel, then bleeding to some extent is controlled. If it was a minor bleeding, it will be controlled. If it was a bigger bleeding, which is the case in most examples, it won't be controlled alone. So, but the first, because just to control the bleeding and stop or decrease the amount of blood being lost. Okay, regardless of how big the injury is. I brought the example of paper cut because this is the first or small example that came to my mind, but this same process works on any other accident. Okay, so how is vasoconstriction induced? It's by two things. First thing is endothelin. Endothelin is released from the blood vessel wall or from the endothelium, secondary to an injury. Once an injury happens to a blood vessel, endothelin will be released, and this will cause vasoconstriction plus neural stimulation. يعني your nervous system will sense this bleeding and will sense this injury, so it will cause vasoconstriction, and this is what we call reflex vasoconstriction, and this is the first step that happens when there's bleeding in your body. Okay, second step is primary hemostasis. Primary hemostasis has a couple of steps written here. Okay, in short, they are literally platelets. Platelets are attracted to the place of injury. This is called platelet adhesion, and then those platelets will change their shape, and then they will secrete the granules they have, and then they will start recruiting more platelets, and this is called aggregation. No, sorry. They will just start recruiting more platelets just to attack them more and more, just to clot or to close this rupture in the blood vessel, as you can see here. And then they will start aggregating in order to build up and just block or close this rupture. I will explain these details in a minute, inshallah. Okay. Yeah. طيب. Those are the first two steps. Endothelium, yes, this slide is just trying, the doctor here is trying to show you that in our body we have many factors and many proteins that either helps in forming a clot or helps in forming a thrombus, or the opposite side of it inhibits thrombosis. Okay, you can see it's written. It either inhibits thrombosis or, as I said, helps form this thrombus. Okay, he's not expecting you to know all of these. He just wants you to know that we have factors and proteins in our body that destroy a clot, and or those are called thrombosis inhibitors, or those that favor thrombosis or try to build a clot. Okay. The third stage is secondary hemostasis, and this is the coagulation cascade. And then finally, we have thrombus and antithrombotic event, which are breaking down the clot after your body خلاص is intact now and your skin is closed and everything is okay. You need to break down that clot, or breaking a clot when it is formed for no reason in your body. And those are antithrombotic events. Again, okay. It says my internet connection is unstable. Okay, this should be good, inshallah. طيب. Again, we stopped here. I said that I said that hemostasis. I've talked about the steps of hemostasis, and I've explained what reflex vasoconstriction is. Then on to the second step, which is primary hemostasis. Primary hemostasis is basically, I told you there are multiple steps which start off with platelet adhesion. Platelet adhesion is basically sticking the platelets, those orange balls are the platelets, into the endothelium surface, which is the vessel wall. This is the vessel wall. This step of primary hemostasis is done by two things. First thing, and the most important factor maybe, and it's the most recurring one, von Willebrand factor. Von Willebrand factor is secreted from the endothelium of the blood vessel after injury directly. And this von Willebrand factor is available on the endothelium surface for the platelets to stick, or the platelets to stick to the endothelium. That's how they that's how platelet adhesion happens. Sorry. Platelets possess it's not a receptor, it's more of a glycoprotein that is called glycoprotein 1b or GP1b. Okay, and this is what helps it stick to the von Willebrand factor. Okay, so the platelets bind to the von Willebrand factor through the glycoprotein 1b. Okay, and that is platelet adhesion. So if you have a question how, or if an SAQ or an MCQ or whatever, how do platelets adhere to the blood vessel? It's through glycoprotein 1b binding to von Willebrand factor. Von Willebrand factor is available on the blood vessel wall or the endothelium, and that's where it's secreted from. It comes from the endothelium of a blood vessel. Okay. Through the and then the platelet has possessed this glycoprotein, which is glycoprotein 1b, that will bind to this von Willebrand factor, and this is platelet adhesion. Okay, second step, or second major step, let me say, is aggregation. You need the platelets to aggregate, to combine together, and then stick to the blood vessel. So you see, you have here a blood vessel that is ruptured. You can see here that, and then it secreted von Willebrand factor. The first platelet came and bound to the von Willebrand factor through glycoprotein 1b. That's adhesion, I said. Okay, then we need the rest of the platelets to come and combine with this platelet, or whatever, how many platelets are here, then to block this rupture of the blood vessel. This is called aggregation. Okay, it's self-explanatory. Aggregation, they aggregate together to block this rupture and stop the bleeding. Okay, how aggregation happens? It happens through two main let me say glycoproteins. Okay, the first one is glycoprotein 2b3a. Okay, it's a complex of two glycoproteins. So glycoprotein 2b and 3a are also on the platelets. This glycoprotein is on the platelet. For fibrinogen, fibrinogen is another thing that I'll be talking about in next two slides, inshallah. Fibrinogen will come. It will bind to the glycoprotein 2b3a in order to form a connection between each platelet. So these small blue balls are fibrinogen. So you see how fibrinogen is binding and combining each platelet to one another. It's binding, first of all, it's binding to the glycoprotein 2b3a on each platelet and forming a chain of platelets. And this is basically aggregation for them all to adhere to the blood vessel through the glycoprotein 1b bound to the von Willebrand factor. So each platelet possesses two glycoproteins, basically. Glycoprotein 1b, yes, glycoprotein 1b in order to bind to the blood vessel, and the glycoprotein 2b3a in order to aggregate and to combine with each other and form a long chain with the help of fibrinogen. Okay, this is primary hemostasis. Once all of this happened, you're done with primary hemostasis. Until this point, what do we have? We have a blood vessel which is ruptured, vasoconstricted as a reflex, first thing to happen. And then platelets came and aggregated all together and then they adhered to the blood vessel just to close this rupture. Okay, so basically, so yeah, this is primary hemostasis. Okay, so we have three things that can go wrong with primary hemostasis, or three defects for primary hemostasis. Uh, first one, let me start with Bernard-Soulier syndrome. It's a deficiency in glycoprotein 1b. Recall what we talked about glycoprotein 1b. It's the glycoprotein that is on the platelet, okay, that will allow the platelet to bind to von Willebrand factor, which is on the endothelium, and allow its adherence. So glycoprotein 1b facilitates platelet adhesion. Okay. In case of Bernard-Soulier syndrome, the patient will not have glycoprotein 1b. So the patient will glycoprotein 1b will be deficient in this patient. Hence, this patient will not have platelet adhesion, because the factor that facilitates platelet adhesion is not there anymore. Okay, and this deficiency is inherited. It's not acquired. Yani if you're not born with it, you can't acquire it from the environment. It's inherited. You have to be born with it. Okay. The second deficiency of the primary hemostasis is called Glanzmann thrombasthenia. Okay, so Glanzmann's thrombasthenia is a deficiency in glycoprotein 2b3a. What did we say about glycoprotein 2b3a? Glycoprotein 2b3a is basically the glycoprotein that is also present on the platelet, but it facilitates platelet aggregation. صح? So what is platelet aggregation? It's just a combination of all platelets together. If we don't have glycoprotein 2b3a, then no platelet aggregation will happen, because what is the facilitator of platelet aggregation? It's glycoprotein 2b3a alongside with fibrinogen. But now we don't have we don't have glycoprotein 2b3a in case of Glanzmann thrombasthenia. So fibrinogen will not find any place to bind between platelets in order to combine them together and form this chain of platelets. So we won't have platelet aggregation. Okay, so if you have any question in the exam, Glanzmann thrombasthenia is a defect, or is a problem in which of the following processes, and then you have platelet adhesion, aggregation, you have bleeding control, you have secondary hemostasis. The answer is platelet aggregation. If you have another question about Bernard-Soulier, then it's an issue with platelet adhesion. Okay. Both of these deficiencies are primary hemostasis deficiencies. Okay, so another, maybe you might get a question such as Bernard-Soulier syndrome is a problem in primary hemostasis or secondary hemostasis. It's in primary hemostasis. Okay, not secondary hemostasis. On to the last deficiency, von Willebrand deficiency. It's, by the way, those two deficiencies, Bernard-Soulier and Glanzmann thrombasthenia, are rare. They are very rare. However, von Willebrand deficiency is the most common, let me say, bleeding hemostasis deficiency. Yeah? It's deficiency. It's called the von Willebrand disease. It's a deficiency in von Willebrand factor. Now, think with me. If you don't have von Willebrand factor, platelets will not bind to anything on the blood vessel. So you have a blood vessel that is ruptured and is bleeding. Okay. Without von Willebrand factor, platelets won't be able to bind to the blood vessel that is ruptured and close this rupture. So platelets will be there, everything will be fine, the aggregation will be fine, and so on. However, platelets are not finding anything to bind to in order to start blocking and closing this rupture or opening that happened in the vessel due to the injury. Hence, this is an issue with platelet adhesion, because platelet adhesion happens due to glycoprotein 1b on the platelet binding to von Willebrand factor on the blood vessel. Now, if you have either of them missing, then you have an issue in platelet adhesion, okay? And that's how bleeding time will be prolonged. طيب. I told you before that Bernard-Solier and Glasman thrombasthenia, both of them are deficiencies in primary hemostasis. Von Willebrand factor is also a primary hemostasis deficiency since it is a problem in platelet adhesion, صح? However, von Willebrand factor has jobs in both primary hemostasis and secondary hemostasis. Now, when I start explaining secondary hemostasis, you'll understand why. So for the time being, it's von Willebrand factor facilitates adhesion. It's for primary hemostasis, but we can't say that von Willebrand factor is primary hemostasis defect because it's both primary hemostasis defect and secondary hemostasis defect. Why? Because von Willebrand factor works as a carrier for factor 8 in the coagulation cascade. Okay, now you will understand this once I start explaining this slide, but wait, just give me a second until I finish this slide. So again, if the doctor asked you a question about what Bernard-Solier syndrome is a deficiency in which of the following processes, it's either primary hemostasis, specifically platelet adhesion. Glanzmann thrombasthenia is also primary adhesion deficiency, specifically platelet aggregation process. Von Willebrand factor is both primary hemostasis deficiency and secondary hemostasis deficiency. Why? Because it facilitates platelet adhesion and it also works as the carrier of factor 8 in the coagulation cascade, which brings me to this slide, which is the coagulation cascade, which is now the secondary hemostasis. I've explained the primary hemostasis here and what goes wrong in primary hemostasis. Now, after primary hemostasis, we have secondary hemostasis. What is secondary hemostasis? Secondary hemostasis is the coagulation cascade working. Okay? What is the coagulation cascade? It's just this process, this chart, or this pathway in which it starts, in which the end result is a clot, okay? Or at least a major ingredient in the clot, or in the thrombus. Now, after I finish explaining this slide, I'll explain the difference between a thrombus and a clot. Like, coagulation cascade has three major pathways: intrinsic pathway, extrinsic pathway, and then common pathway. What is the difference between each pathway? Let's start with extrinsic pathway. It's the easiest. Extrinsic pathway is triggered or stimulated or starts due to an external injury. So a paper cut, for example, an accident, a trauma, and so on. Okay, how does it start or what triggers it? Tissue injury, trauma basically, or any accident or a paper cut, for example. Tissue injury will secrete tissue factor. What is tissue factor? It's thromboplastin. Okay, tissue factor will bind with factor 7 and activate it in order for factor 7 to start the common pathway. طيب? This is an extrinsic pathway. It's very easy. It's only factor 7. Extrinsic pathway is basically tissue factor activating factor 7. That's it. This easy. What is the cause of it? Tissue injury, because tissue factor is only secreted due to tissue injury. طيب? Intrinsic pathway, on the other hand, is a process that is going on in our bodies always. For example, it's happening for me now while I'm explaining this lecture, for you while studying, for your mother while cooking, and so on. Or it's happening for everyone inside due to the minor bleedings that I talked about in the beginning. طيب, it does not require injury to start because it starts due to minor bleedings inside. That's why it's called intrinsic pathway. Before I start talking about intrinsic and common pathway, which will take us long, the doctor will not ask you about each factor per se. He's not expecting you to memorize every step in the coagulation cascade. However, he wants you to know the clinical aspect of the coagulation cascade, and I will be explaining clearly now, inshallah. طيب. I started with extrinsic pathway because it's the easiest and it's only factor 7, and then maybe that's one of them that you need to know. And also there are two mnemonics that you can know, and you can easily memorize the intrinsic and extrinsic pathways factors. You don't steps and so on are too مشوار يعني. Okay. The endpoint again, the endpoint of intrinsic and extrinsic pathway, they need to end up in the common pathway. That's why it's called common pathway. And the end result of the common pathway, or the endpoint, is forming fibrin or cross-linking fibrin to because fibrin is the clot basically, or is the thrombus. طيب. So let me give you the mnemonics. Intrinsic pathway, what are the factors that are in intrinsic pathway? They are 8, 9, 10, and 8, 9, 11, 12. Okay, 8, 9, 11, 12. A here means activated. You see, each factor activates factor 7 in extrinsic pathway. This is here, it's activated here, it's activated here, it's activated there, and so on. So what is the يعني, it's not a mnemonic, it's just making it easier. What are the factors in the intrinsic pathway? 7, 8. No, astaghfirullah. What are, sorry again. What are the factors in the intrinsic pathway? 8, 9, 11, 12. 8, 9, 11, 12. That's intrinsic pathway. Common pathway, what are the factors in common pathway? They are 1, 2, 5, and 10. How do you memorize this? 1 times 2 times 5 equals 10. So 2 times 5 is 10, and then 1 in the beginning. 1, 2, 5, 10. It's easy, okay? Those are the factors for the coagulation pathway. What are the clinical aspects of this coagulation pathway? You also need to know that the coagulation pathway requires phospholipid surface and calcium in order to make the cross-linked fibrin. Where do we get the phospholipid pathway? The phospholipid surface. It's from the platelets. I didn't explain it before until now because I feel like this is the perfect place to explain it in. So I told you in primary hemostasis, we have platelet adhesion and aggregation. Those are the two main processes. But after platelets adhere to the blood vessel surface, they change their shape. They become more flat. Why? In order to give more surface area, or to give more phospholipid surface area for the coagulation pathway and the factors in the coagulation cascade to work, because they require a phospholipid surface. And this phospholipid surface comes from the platelet surface, which became flat once they adhere to the blood vessel wall, in order to provide this phospholipid surface for the factors to get activated. Calcium also comes from the platelets, by the way, and from the endothelium of the blood vessel. The third major clinical aspect you need to know is factor 13. Factor 13 or before factor 13, let me talk about fibrin. طيب, I told you the endpoint of the whole coagulation cascade is cross-linked fibrin. Fibrinogen, when I say fibrinogen, plasminogen, and so on, these are the inactivated form of this factor. Fibrin is the activated, thrombin is the activated, prothrombin is not active, and so on. So fibrin is the active form of fibrinogen. You need to activate fibrinogen, and this requires calcium. Again, I told you calcium is required alongside with the phospholipid surface, and yellow highlight here is the phospholipid surface. Through calcium, you form fibrin. Now, I said fibrin is the major ingredient of the thrombus, the clot. طيب. However, fibrin alone is not enough, or not strong enough. Okay, you need to cross-link it in order for it to become strong enough to form this clot and close and stop the bleeding, because the clot will block the site of bleeding. طيب. How does your body cross-link the fibrin? Through factor 13. Factor 13 here requires calcium to be activated. Once it's activated, it will cross-link the fibrin, and now we have ready strong fibrin to form the clot that we need in order to stop this bleeding. Again, what are the four important clinical aspects of the coagulation cascade? The phospholipid surface that comes from the flattening of the platelets after adherence, after adhesion, and the calcium that also comes from platelets, fibrin, and factor 13, which cross-links fibrin. So if you had a question in the exam, what cross-links fibrin? It's factor 13. I think this question will come. I remember the doctor here said a couple of questions, gave two scenarios that I wrote. Okay. No, not here. Wait. I want also to tell you about the difference between the thrombus and the clot. Clot, basically, they are the same, okay? But for the science or the book reason, let me tell you the difference between them. Clot forms after the person has died. So if you ever seen an animal died or blood in this somewhere, you will see it became agglutinated and it formed clots. These agglutinations of blood are called clots. However, any clot in your body while living, while a person is alive, is called a thrombus. That's basically the difference between them. And you can see here again, von Willebrand factor is a carrier of factor 8. That's why von Willebrand disease is a defect in both primary hemostasis and secondary hemostasis, because in primary hemostasis it facilitates platelet adhesion, and in secondary hemostasis it's a carrier of factor 8, which is a factor for the intrinsic pathway. Okay, so without von Willebrand factor, such as in the case of von Willebrand disease, you won't have platelet adhesion, so your primary hemostasis will be deficient, and the secondary hemostasis will also be deficient because factor 8 will not have a carrier. So basically you will have a deficiency in factor 8 because it's there. It's not that the levels of factor 8 are less, but they are not working because no von Willebrand factor to carry them from the liver, which is the place where they were made, to the rest of the place where we need them in. Okay, and also again, von Willebrand disease is also an inherited deficiency. It's not acquired. You cannot acquire it from environment. You need to inherit it from your family. Now let's talk about. Now we finished the hemostasis process itself. We finished talking about how your body controls bleeding, or at least the major part of this process, which again, if I want to go over it quickly, it's the reflex vasoconstriction, which is caused by the endothelium released and the neuronal stimulation, and primary hemostasis, which is basically platelet adhesion through von Willebrand factor and glycoprotein 1b. And then the platelets will change their shape, become more flat, and provide the phospholipid surface for the coagulation cascade factors. And then platelets will also aggregate through glycoprotein 2b3a alongside with fibrinogen. That's basically primary hemostasis. Then secondary hemostasis, which is the coagulation cascade, in order to form the endpoint, which was the cross-linked fibrin. The cross-linked fibrin requires factor 13 in order to be cross-linked, or in order for fibrin to be cross-linked. Okay, we also need calcium and phospholipid surface, with both of them come from the platelets. And that's basically secondary hemostasis. Right. Now let me talk about causes of bleeding and what might start all of this from, and let me also talk about some abnormalities that might happen throughout the whole process. What are some causes of bleeding? As I told you in the beginning of the lecture, what are the three main corners, let me say, of hemostasis? I said vascular integrity, platelet function, and then the last one is normal levels and function of the coagulation proteins or factors. So if we have any of these that is not there, or something is wrong in any of these, then we will have bleeding, or we won't have we won't have hemostasis, because hemostasis is the process of controlling bleeding. If we have one of these not available, or there is a problem in one of these, then hemostasis will not work well. So for example, impaired vascular integrity, I told you, if the blood vessel wall is so thin for any reason, or any disease made this blood vessel wall very thin, then it will be impaired, and it won't bear the pressure of the blood, and it will rupture. This will cause bleeding. Okay. Or thrombocytopenia, or inherited or acquired platelet function defects. What is thrombocytopenia, as you might know by now, is deficiency in platelet number. or any inherited or acquired platelet function defects. You might have enough number or enough amount of platelets, however, they are not functioning or working well. Also, if you have a deficiency in any clotting factor, from 1 to 13, because without يعني if any of them was missing, then you won't have the whole cascade working well. Because if you read it well here, every factor depends on the factor before it to be activated and so on. Okay. And if you have factor 13 defective, then you won't have the fibrin cross-linked, then you won't have the fibrin strong enough in order to form thrombus we want to stop this bleeding. Like, how would the patient present if they have excess bleeding or prolonged bleeding, or if they have an issue in bleeding? They will present in they will present, these are the manifestations or presentations that they will present with. They are easily bruised. They have a lot of bruises on their body because they are easily bruised, and they get bruised often. Okay. Mucosal bleeds, they have oral mucosal bleeds, or from their nose, which is also called epistaxis. I will show you to you in a couple of slides coming. Prolonged bleeding following cuts and incision. All of us get cuts, or paper cuts or knife cuts or so on. It happens, but and the bleeding has to stop in a couple of minutes. If it did not stop, or it took so long to stop, then this is an issue with bleeding, as called as prolonged bleeding. يعني. Hematomas, they are collection of blood under the skin. Hemarthrosis is collection of blood in the joints. And intracranial or intra-abdominal bleeding, it's just internal bleeding, not due to any injury. You have an issue with hemostasis, so you can easily bleed, and you can't stop this bleeding. Hence, you will have intracranial bleeding inside your cranium or inside your head, inside your skull, and intra-abdominal, which is inside your abdomen. Okay. Yeah. Clinical details, you have hereditary and acquired. Hereditary is inherited. You inherit this deficiency, such as the ones we talked about: von Willebrand disease, Bernard-Soulier syndrome, and Glanzmann thrombocythemia syndrome. Acquired, what are examples of acquired bleeding issues or problems? They are, for example, when you take anticoagulants or antiplatelets such as aspirin, heparin, warfarin, and so on. All of these, they let me say, they inhibit hemostasis because they affect one of its processes or one of its steps. Hence, they affect hemostasis. Hence, you will have prolonged bleeding time. For example, if a patient is on heparin and they got cut, then they will lose a lot of blood because their body cannot control this bleeding, because they are taking a drug that is inhibiting the process that controls the bleeding, which is called hemostasis. This is acquired bleeding deficiencies or bleeding problems. Okay. Types of bleeding, we have two types: mucocutaneous and within a cavity. Mucocutaneous is, for example, bleeding from your nose, which is called epistaxis. I talked about it. And mucocutaneous is a sign of platelet deficiency. Or we can have bleeding within a cavity, such as hematomas and hemarthrosis. I said hematomas are collection of blood under the skin, which is basically coming from a cavity, or hemarthrosis, that is collection of blood in your joints. So you are bleeding in your joints, that's also within a cavity. And bleeding within a cavity is a sign of clotting cascade or coagulation cascade factors deficiency. So protein factors deficiency, factor 8, 9, 10, 11, so on. I'll give you examples for protein 8, which is the intrinsic pathway factor, is hemophilia A. Protein 9, which is also an intrinsic factor, it's hemophilia B. And factor 11, which is also an intrinsic pathway factor, it's hemophilia C. And then the last intrinsic pathway factor is 12. There is no name for its deficiency. We have hemophilia A, B, and C, 8, 9, and 11. They are all intrinsic pathway factors. And again, yeah, these are factors, and the patient that has deficiency in a factor from the coagulation cascade will present with bleeding in the cavity, such as hematoma and hemarthrosis. طيب, there is also severity of the bleeding. Is it unprovoked? Is it spontaneous? Is it on hemostatic changes? يعني, is it due to an injury? Do you bleed suddenly out of nowhere? And so on. And also, doctors have to keep in mind the frequency of bleeding. How often do you bleed? Do you bleed for some small reasons that don't require bleeding? You bleed because you don't have the process of controlling this bleeding, or hemostasis working well. Do you bleed too often, and so on? And timing of the bleeding, is it immediate or delayed? So if you're injured, do you bleed immediately, or do you bleed immediately, or is bleeding delayed for you? I'll explain why. So we all, any one of us, or any healthy person gets a paper cut or an injury or an accident, la samah Allah, will start bleeding immediately, and then your body will try to control this bleeding. If it was successful, you will no more bleed. And all of this happens within a time frame which we call bleeding time, basically. Okay. And some patients will have their bleeding time delayed. So they get a paper cut or any cut, they start bleeding, then their body controls this bleeding within the time frame, within the normal time frame. However, after a couple of minutes, they will bleed again from the same location. I will tell you why. This is because, remember factor 13, I told first of all, these patients have factor 13 deficiency. Why? Remember how I told you factor 13 cross-links fibrin in order to make it strong enough to form the thrombus we need for to block this cut? Yes, in patients who have factor 13 deficiency, cannot block the bleeding using a clot. So once they have a cut, their blood will vasoconstrict and primary hemostasis. This is good enough to stop the bleeding temporarily. Okay, it won't stop the bleeding for good. We need fibrin to form a clot in order to close this opening or this bleeding. طيب. So why do they have a break between bleedings? Let me say, because their blood successfully controlled the bleeding. Their body successfully controlled the bleeding, and then after that, instead of the clot coming and stop and then closing this opening for good, no, this clot is not working enough because the fibrin was not cross-linked by factor 13. So the cut will open again and will start bleeding again, and that's delayed. The doctor is trying to tell you that acquired deficiencies of bleeding, not acquired, sorry, hereditary, or those that are inherited from the family and not acquired from the environment. He's just trying to explain the genetics behind it here. I think you must know this by now, since you're studying genetics, that an X-linked recessive inheritance if a father was affected, he will not give it if the father has a deficiency that is X-linked recessive, all of his sons will be unaffected, and all of his daughters will be carriers. Why? Because the father is giving his male sons, the Y chromosome, which is unaffected. It's healthy, and he's giving his daughters the affected X chromosome, so they became carriers. Okay, he's just basically explaining this. You know this by now, inshallah. Let me not waste time on it. Physical examination. Like, what is physical examination? Physical examination is basically what will you see in a patient who has bleeding issues. Okay, we explained here the details and how do they present. How do they present when you first see them and start talking to them. But here, physical examination is when you start examining them yourself as a doctor. What will you see? You will see cutaneous bleeding. This is called petechial bleeding. Petechial bleeding is you see those small red dots? Yes, this is blood. So these are the very small vessels under your skin are rupturing and blood is leaking out to the skin up and forming those small dots. Mucosal bleeding, this is epistaxis. Epistaxis is bleeding from your nose. So patients will present with often epistaxis, mucosal bleeding. And remember what I just said about mucosal bleeding. sorry, or mucocutaneous bleeding, it's indicative of platelet deficiency. They will also present with bruising. As I said before, they bruise a lot. They bruise for no reason. They will find their body full of bruises on their legs with no reason. So I know bruising can happen due to trauma or due to many reasons. However, those patients will bruise for no reason, basically. Hemarthrosis is basically blood in the joints. You see here how the joints are inflamed and they enlarged because there is blood in the joints. This patient also has bruises. These are bruises here and there. Okay, these are physical examinations. What would you see on lab tests? Now, before screening for lab tests, you need to make sure for two things: that this patient has not received any transfusions, because you want to test their normal levels of platelets. You want to check their normal level of the levels of platelets in their body. So you don't want them to be altered more or high, less or low, because during transfusion, yes, platelets will increase because they are gaining more blood. Okay. You can, if they are on blood transfusion, you will not get the correct platelets levels of their own body. If they are on drugs, I told you, anticoagulants and antiplatelets like aspirin, NSAIDs, antibiotics, ibuprofen, heparin, warfarin, those drugs, they all alter the process or hemostasis, basically. So all of these will show false negatives and false positives, and you don't want all of this. What are the tests that you can screen or that you can do to test hemostasis? We have two types: first line tests and second line tests. First line tests, you check what is the major problem, and then the second line, you specify specifically what is the issue. I'll show you examples now. First line tests are easy to perform and simple, quick. And they also, the important point about first line tests I told you about is that they direct you towards what is the next investigation, what is the best next investigation. Tests: platelet count and morphology, bleeding time, prothrombin time, and activated partial thromboplastin time, and factor 13. One by one. Platelet count. You need to check for the platelet counts and their function or their morphology, basically. Because patient with thrombocytopenia or the low platelet counts will have increased high bleeding or prolonged bleeding time, because there are no platelets to stop this bleeding, basically. Or also, you might have enough platelet counts, however, the morphology or the function of the platelets are not working well enough. Bleeding time. You need to check the bleeding time, because this is the first sign. Any patient with any issue with hemostasis will present with prolonged bleeding time. They also call it PFA 100. It's just a new test. It's more efficient and more fast. There's a whole slide about it. Prothrombin time and or PT, and activated partial thromboplastin time, or APTT. These tests test for the secondary hemostasis or coagulation cascade. Now I will talk about them in details. Each of them tests certain factors in the coagulation cascade. These are the first line tests, first investigations, first things you test for in any patient who you suspect has bleeding issues. And you also test for factor 13, because neither PT nor APTT will show you results for factor 13. You have to test for factor 13 itself, because it might be deficient. As I told you, patients who present with delayed bleeding. Okay. Platelets. Let's talk about the first test, which is platelet counts and morphology. You assess for the platelet counts. Are they large? Are they giant? Are they low? You test for all of these. You assess also the function of how do you assess the platelet function? Through bleeding time or PFA 100. I told you PFA 100 is better. It's the new test. How do you test for bleeding time? Through something called Lancet standardized template. It's just this template, and then you check when will their body stop bleeding. The normal range is usually from 2 to 6 minutes. Your body has to stop bleeding within the range of 2 to 6 minutes. PFA 100 is better than this test. Basically, it's better than Lancet standardized template. It's faster. It's more efficient. I can say it's computerized. It's an analyzer, basically. That's why it's better. Okay. What causes prolonged bleeding time? I talked about this, or no harm of repeating them quickly. Low platelets. I told you low platelets will cause bleeding time because you don't have enough platelets to block this bleeding. Inherited functional disorders such as von Willebrand disease, Bernard-Soulier syndrome, Glanzmann, thrombocytopenia, also acquired defects. Just think of these like taking drugs such as aspirin and so on. Okay. Okay. Now, screening for coagulation pathways. Remember the tests I told you about, that tests for the coagulation pathway, they are PT and APTT. These tests for the coagulation pathways. Yes, you need to know this. Principle is that the principle of these tests is that they are activated by adding calcium plus an activated agent. So they take the blood, they put activating agents into them and calcium, and see when will the clot happen, how much will it take for this for the clot to happen, and that's how they will know the PT is prolonged or the APTT is prolonged, because you use different activating agents for both, since each of them tests certain coagulation pathways. Okay, so you test for both, and according to the result, you can tell which factor in the coagulation. You can't tell which factor specifically, but you can tell which pathway, is it the intrinsic, extrinsic, or the common pathway within the coagulation cascade is affected. طيب, I explained all of this, and then the endpoint I told you is cross-linked fibrin, which requires factor 13. However, none of these tests will measure factor 13. So there is a specific test for factor 13 I'll talk about later, inshallah. Yes. طيب, let's talk about PT-INR. The doctor doesn't want you to go into details for this because you will take this in POD next year, inshallah. However, you have to know that PT tests for the extrinsic and the common pathway. APTT measures the intrinsic and the common pathway. طيب, what is the factor, the factor for the extrinsic pathway? It's factor 7, صح? And then the common pathway. So if you have prolonged PT, then there is an issue with the extrinsic pathway or the common pathway. And these are the factors that PT screens: factor 2, 5, 7, extrinsic, 10, and fibrinogen. 2, 5, 10, and fibrinogen are all common pathway. Sorry. APTT measures intrinsic and common pathway. They screen factors 1, 2, 5, 8, 9, 10, 11, 12. So 8, 9, 11, 12 are all intrinsic pathway factors. 1, 2, 5, 10 are common pathway factors. طيب. I told you there is specific activating factor for each test, either PT or IPTT. For PT, you have to add, you take the blood, the patient's plasma without calcium, okay, and then you add thromboplastin with calcium. Thromboplastin is just a combination of phospholipids and something that acts like tissue factor. Let's stop here. Remember, PT tests for the extrinsic pathway, or basically factor 7, since factor 7 is the only factor for extrinsic pathway. And recall with me what starts or what triggers and stimulates the extrinsic pathway. It's tissue injury secreting tissue factor. But if we have plasma and we want to test if the extrinsic pathway is working, we need to add tissue factor, because tissue factor is secreted through tissue injury. So we need this tissue factor in order to activate the extrinsic pathway. And we also need phospholipids and calcium, because I told you, without because the whole coagulation cascade requires calcium and phospholipids, which come from platelets, okay, to work. So you need to add both of these in addition to tissue factor to test if factor 7 is working. Because if you add a tissue factor and then PT took too long to start, then there is something wrong with the extrinsic pathway, and specifically factor 7, since the extrinsic pathway has only factor 7, okay? Because you're adding the activators of factor 7. That's what I wanted to say. And this exactly says what I explained. And adding thromboplastin to the patient's plasma will activate the extrinsic pathway. Then you just measure the time in seconds it takes to make fibrin. And why fibrin? Because remember, the end point is fibrin. So the whole coagulation pathway will give us fibrin, and then factor 13 will cross-link the fibrin. That's why neither PT nor APTT will test factor 13, because the endpoint is just fibrin. It's the step before cross-linking, or the step before factor 13 works. PT tests for warfarin as well, or Coumadin, the other name for warfarin. There is a mnemonic for differentiating between PT and APTT. So what the mnemonic is, PT stands for, or the mnemonic says it stands for playing tennis. It stands for prothrombin time. However, there's no however here. It's just a mnemonic that says PT is play tennis and tennis is played outside. So it's the extrinsic pathway. This is a well-known mnemonic. I added to it this part, which is warfarin, because I messed up between PT and APTT. APT tests for heparin, and the PT tests for warfarin, and I keep confusing them. So I said warfarin. War happens outside, and tennis is played outside, which is the extrinsic pathway, and then warfarin, war is outside. They all fit together, as in play tennis outside, war outside, and then extrinsic pathway as in externally. Okay, you also use PT to evaluate people in liver failure. Why? Because I told you all factors of the coagulation cascade are manufactured in the liver. So if a patient has liver failure, will present with prolonged PT and APTT as well, because all the coagulation factors will be deficient in a liver failure patient. DIC, or disseminated intravascular coagulation. Don't go into deep in this. You will take it in details in POD, inshallah, and also in year 3. But basically, the disseminated intravascular coagulation, there is a lot of bleeding and a lot of coagulation in the same time, that the body is using all the coagulation factors. So in a patient who has DIC, and it's an emergency, by the way, if a patient has the DIC, they are using all their coagulation factors. Hence, PT and APTT will normally be prolonged, because no more factors to be tested or screened. طيب. It tests factor 7 because PT is for is for the extrinsic pathway, and extrinsic pathway is only factor 7. I mentioned this a lot. It's also used as pre-operation screening panel, just to check the you do everything pre-operation, just to limit any complications during the operation. APTT is okay, let's talk about how do we do APTT first. Same thing, you take the plasma without the calcium and you add phospholipid plus calcium. The difference between APTT and PTT is that you don't add full thromboplastin, literally partial thromboplastin. That's all. It's written here, you can read it all the way. It does not require explanation. The only difference between APTT and PTT is the activating factor, which is partial thromboplastin, and there you add full thromboplastin. That's why it's called I forgot what this APTT stands for. Nice. I want to go back. Okay. Activated partial thromboplastin time. So partial thromboplastin, and this is prothrombin time. Like, okay, what do we use APTT for? It's to monitor patients on heparin. I told you warfarin for PT and heparin for APTT. Or on other hand, or in other words, you monitor patients on warfarin using PT, and you monitor patients on heparin using APTT. Okay? Also, to test for factors 8, 9 deficiencies, and also in some cases von Willebrand deficiency. Why? Because von Willebrand factor is a carrier of factor 8, and factor 8 is a part of the intrinsic pathway. Hence, you can use APTT to test for to check for von Willebrand deficiency. The mnemonic here for APTT, TT stands for table tennis, and you play table tennis inside. You don't play it outside. It's an indoor sport, not an outdoor sport. So indoor, intrinsic, that's how you know it's intrinsic pathway factors. APTT is also used to evaluate patients in liver failure, same reason for why you use PT. Also DIC, same reason, and also pre-op screening panel for the same reason. The only difference here is heparin and intrinsic pathway factors, which are 8, 9, 11, and 12. And remember, those are hemophilia A, B, C. So a patient with hemophilia A, B, C will present with prolonged APTT. طيب. This is prolonged APTT. I will give you a question now. طيب. Prolonged, when will, who or which patients will present with prolonged PT and APTT? They are basically patients with deficiency of common pathway factors. And so this slide talks about PT and APTT prolonged, not one of them. You basically order both of them to screen a patient who you suspect has a bleeding problem. Usually one of them comes prolonged and the other is normal. So if PT came prolonged, then there's a problem in the extrinsic pathway. If APTT came prolonged and PT was normal, then there's a problem in the intrinsic pathway. If both of them became prolonged, then it's an issue with common pathway, okay? Because this is an overlap between both of them. You can't have a deficiency in the common pathway and only one of them is prolonged because it doesn't make sense, because both of them has to be prolonged if there's a deficiency in the common pathway, because a common pathway is overlapping between both tests. Vitamin K deficiency. Vitamin K is used for those factors. I forgot them. 2, 7, 9, and 10. So factors 2, 7, 9, 10 require vitamin K, and patients with vitamin K deficiency will present with, or among screening, among lab tests, will have their PT and APTT prolonged. If you wanna think about this, factors 2, 7, 9, and 10 are both intrinsic, extrinsic, and common, because 7 is, let's start from 2. 2 is common pathway, 7 is extrinsic pathway, 9 is intrinsic pathway, and 10 is common pathway. So if a patient has vitamin K deficiency, he basically has a deficiency in all pathways of the coagulation cascade, and this is another huge reason why PT and APTT will be prolonged, as I explained in the first point. Liver disease and DIC are kind of the same, since both of them will cause deficiency in all factors of the coagulation cascade, not just one pathway. The liver disease, because the factory of making those factors is not working anymore in liver disease, it's the liver. DIC, you're using all your factors, so both APT and APTT will be prolonged. Factor 13. We have to test factor 13 itself because neither PT nor APTT will test for factor 13, because I told you the endpoint of the coagulation cascade is fibrin, and that's what we're testing for. In PT and APTT, we're testing for the time it takes to form fibrin. We don't test for the cross-linking of fibrin, which is done by factor 13. We need another test, which is called the clot solubility test. This clot solubility test screens factor 13. Basically, easily, clots formed in the absence of factor 13 are unstable and will dissolve rapidly. Okay, so they take the plasma, they add, they check the clot, they wait until the clot is formed in the plasma, and then they take this clot. If it was unstable due to the absence of factor 13, it will dissolve. If it did not dissolve, then factor 13 is there. Remember again, factor 13 is used to cross-link fibrin, in other words, to make it more stable and stronger to form a clot. Okay. Second line tests, I told you we use first line tests to figure out the issue, and then second line tests to pinpoint and determine and confirm directly what is specifically the issue. So if PT or APTT was prolonged, one of them were prolonged, then this shows either the intrinsic or the extrinsic pathway has a problem. So for example, if APTT was prolonged and PT was normal, then there is an issue in the intrinsic pathway. But which factor in the intrinsic pathway? Then you have to do a factor assay in order to know which factor of the intrinsic pathway is deficient, or the common pathway, and so on. That's why first line tests are direct you toward the second line tests and the best investigation to do. Platelet function test, because maybe coagulation cascade is working well. However, there's an issue in platelet function. So if there's an issue in platelet function, or in platelets generally, and you made the first line tests and you figured out that there's an issue with the platelets. Now you need to know, is it the function? Is it the morphology? That's where the second line test comes in. Yeah, I think we're done with tests. I just want to give you 2-3 questions now. Let it be after this slide. Type. Practice points. This is what you basically do to a patient that comes in. You take patient comes with a history of bleeding, any type of bleeding, epistaxis, hemarthrosis, bruising, any history of bleeding. So you take the history of bleeding, and then you perform your physical examination. You might see bruising, you might see petechial rash, you might see anything on the physical examination that I explained before, and then you start ordering first-line tests. The first-line tests are the CBC, with peripheral film review, in order to see the blood cells, all blood cells, the numbers, and how are they working. You know CBC by now. And then you also test for the bleeding time. To see the function of or to test platelets generally, PT, extrinsic and common pathway, APTT, intrinsic and common pathway, then urea clot lysis test to see if the body is lysing the clots right away, or is there a problem in lysing the clots, basically. طيب. You also order specific tests used in initial results. Refer to the hematologist in case of suspicion. If you suspect any other bleeding, you refer to a hematologist if you were not one of them. We finished the first part. We're almost done with the lecture. We just have a couple of slides. Let's talk about thrombosis. They are easy. Next slides are easy. I just want to ask you some questions. So let's say a patient presents with I wrote them down, by the way. Deficient bleeding time, or sorry, prolonged bleeding time, normal platelet function, APTT was normal and PT was prolonged. What is the problem here? Extrinsic pathway. And we don't need further second line, because in extrinsic pathway is factor 7. So we directly say it's a factor 7 deficiency. Extrinsic pathway, specifically factor 7. طيب. Why isn't it not common pathway, for example, since PT also tests for common pathways, صح? I would say it's not common pathway deficiency, because if it was common pathway deficiency, APTT also has to be prolonged, since common pathway overlaps between PT and APTT. But since APTT is normal, it's not prolonged, then the common pathway has to be fine. Intrinsic pathway has to be fine. However, extrinsic is the issue. If we had the same patient but with APTT prolonged and PT was normal, then we will have APTT prolonged. PT is normal, bleeding time is prolonged as well, since this is the main issue. And the platelets were normal, then we will have an issue in intrinsic pathway only. We have to do a second line test in order to find out, or to do the factor assay in order to find out which factor specifically. Why not common pathway? Simply because the PT was normal. طيب. If a patient presents with both PT and APTT prolonged, bleeding time prolonged, platelet function test normal, what would be your diagnosis? It will be an issue with common pathway. You need to do further second line tests in order to figure out which factor in the common pathway is the defect. Okay, let's talk about thrombosis. So we said hemostasis is normally happening in all our bodies, and this is beneficial for our minor bleedings that happening in us all the time. However, if it was inappropriately activated, then this is harmful, and this will cause thrombus and clots in our body, and this will cause huge disasters and diseases. طيب, we have three predisposing situations or factors known as Virchow's triad or Virchow's triad, whatever you want. The first one is changes in intimal surface of the vessel, changes in the pattern of blood flow, and changes in the blood constituents. طيب, remember the first slide I explained, which talked about the three main corners of, I call them corners of hemostasis. It was integrity of the blood vessel, platelet function and amount, and the third one was coagulation factors, صح? You can tell here they relate to some extent. So intimal surface of the blood vessel is the integrity of the blood vessel. Changes in the pattern of blood flow, that's basically the platelet function, because if platelet amounts or number of platelets will change the blood flow, okay? And changes in blood constituents, just think of them as the coagulation factors, why not? طيب, anti-clotting, we have a clot, okay? We want to lyse this clot or stop this clot. We have two steps. First step is you have to inhibit the cascade or the coagulation cascade, which is forming the clot, which is forming the cross-linked fibrin. We need to inhibit this cascade to stop making new clots, and then we need to lyse all clots that were made in the body. What are cascade inhibitors? TFPI1, antithrombin 3, proteins C and S. I will talk about each one of them later. And what are the factors that lyse the clots? They are TPA and plasmin. Then you have the clot lyses the clots, okay, that will resolve in the blood. طيب, fibrinolysis. Okay, fibrinolysis is basically lysing of the clot, okay, which is this step two, okay. طيب. It has a main enzyme that is called tissue plasminogen activator, and there is a clinical aspect of this I will tell you about. The tissue plasminogen activator, or TPA, basically activates plasminogen or activates plasmin, which was plasminogen inactivated. TPA also comes from the endothelium. Plasmin will then digest the fibrin, okay, and other coagulants or other clots. Then they will become fibrin degradation products. Plasmin will digest the fibrin, which is the main ingredient in the clot. If fibrin was digested, no more, we will not have clot. We will have something called fibrin degradation products, okay, which will resolve in the blood later on. Yep. We have two inhibitors of this process this process called fibrinolysis, because you are lysing fibrin or lysing the clot. We have two inhibitors of this process. The first one is alpha-2 antiplasmin. It inhibits plasmin, so it prevents plasmin from digesting fibrin. Another one is also called plasminogen activator inhibitor 1 and 2. We have two inhibitors for plasminogen activator, which is TPA. If we inhibited TPA, we will not activate plasmin, so we won't digest the fibrin because we need to activate the plasmin. What is the clinical aspect of TPA? You can, if a patient presents with a stroke or any type of an issue that is caused by a clot in the body, you give them TPA. You give them tissue plasminogen activator. You inject them with TPA, and that's how you start. You activate the plasma in their body to digest that clot. Okay, type those are the cascade or coagulation cascade inhibitors. We have 3. The doctor didn't said that you need to know these actually. You need to remember all of these. They are protein C, antithrombin 3, and then TFPI. Okay, and then TFPI. You can see here protein C inhibits factor 8 and factor 10. Factor 8 is an intrinsic factor, intrinsic pathway factor, and factor 10 is a common pathway factor. Antithrombin 3 is the most potent one. It's the one that inhibits everything. It inhibits factor 7 in the extrinsic pathway. It also inhibits factor 11 in the intrinsic pathway, and factor 9 in the intrinsic pathway also. It also inhibits factor 10 and thrombin in the common pathway. TFPI finally inhibits tissue factor. Tissue factor, yeah, it inhibits tissue factor and factor 7. So you have 3, protein C, antithrombin 3, and TFPI. I think it stands for tissue factor plasminogen inhibitor, okay? So again, one last time, TFPI inhibits the extrinsic pathway or tissue factor and factor 7. Protein C inhibits the intrinsic pathway and part of the common pathway, specifically factor 8. Factor 8 is from the intrinsic pathway and factor 10 from the common pathway. Antithrombin 3, the most strong one, the strongest one, inhibits inhibits all pathways. From the extrinsic pathway, it inhibits factor 7. From the activated factor 7, in the intrinsic pathway, it inhibits factor 11 and factor 9, and in the common pathway, it inhibits factor 10 and thrombin, which is factor 1. طيب, this is Virchow's triad. I told you 3, it's called triad because it has 3 main elements: endothelial injury, abnormal blood flow, and hypercoagulability. طيب, let me go over them quickly. Endothelial injury, where it's any disturbance in the dynamic balance of the pro-thrombotic and antithrombotic activities of endothelium can influence local clotting events. So endothelium, or the blood, the vessel wall, is disrupted. Then this will affect the antithrombotic activities and the prothrombotic activities. Simply, you don't need to go into details. Blood flow. Our blood flow in healthy people is laminar, as you saw in CVP. However, the laminar blood flow can be turbulent for many reasons, or can be called stasis. What is stasis? It's just it's not the blood flow is no more laminar, it became turbulent or stasis. Stasis is a major contributor in developing venous thrombi because the blood is, the blood it flows in a laminar way. Remember, in CVP, if it became turbulent, it's unorganized. The blood cells are unorganized. This turbulence will contribute to the arterial and cardiac thrombosis by causing endothelial injury or dysfunction. Endothelial injury will cause the clot, basically, okay? As well as by forming countercurrents and local pockets of stasis. Local pockets of stasis are literally pockets in the blood vessels. You don't need to go to details. You'll study them all in POD, inshallah. However, pockets of stasis will disturb the laminar blood flow, which will cause venous thrombi. At the end of the day, I want you to keep in mind that whenever the blood is not moving, is not flowing, it will cause clots directly, as in stasis and turbulence. They will lead into endothelial activation, enhancing procoagulant activity and leukocyte adhesion, disrupted laminar flow, and bring platelets into contact with the endothelium. Platelets will come, which will cause the adhesion and aggregation. Endothelial activation, which will activate the coagulation cascade pathways. All of these will help form the clots. They will prevent washout and dilution of activated clotting factors by fresh flowing blood and the inflow of clotting factors. He's saying that fresh flowing blood helps flush away the clots. However, that's in the case of laminar blood flow. In case of turbulence or stasis, there is no fresh flowing blood in a laminar way that will flush out these clots. They are sitting in their place and forming clots. And as I said, remember this: if blood is not flowing well, clots will happen. Then finally, hypercoagulable states. There are 2, primary and secondary. Primary is genetic or inherited, such as factor 5 laden, it's called, or a mutation of factor 5. Antithrombin 3 deficiency, protein C deficiency, protein S deficiency. What are these? Remember, these 3 are inhibitors of the coagulation cascade pathway. Let me go back for you to remember. Remember this slide: protein C and protein S. They inhibit intrinsic and intrinsic and factor 8 and factor 10 from the common pathway. So if we have deficiency in one of these, you won't be able to inhibit the coagulation cascade, so your body will keep on forming clots. Okay, and these, and also antithrombin 3. Antithrombin 3, remember, it's the most potent, strongest inhibitor of the coagulation cascade. Between them, it inhibits all three pathways: intrinsic, extrinsic, and common. Any deficiency in those three will lead to hypercoagulated states. Why? Because the coagulation cascade is just working like crazy and forming clots. There is no inhibition on this coagulation cascade. You need this balance of activation and inhibition, activating it when you need it, and then that's beneficial, and inhibiting it when you no more need it, because if you did not inhibit it when you don't need it anymore, it will form clots in your body. And that will cause the vascular and cardiac issues. And if, and those are inherited, okay? You can't acquire them. Secondary is acquired. Some things that carry high risk of thrombosis are prolonged bed rest or immobilization, tissue injury, and cancer. Prolonged bed rest, I think you know this by now. If someone is hospitalized for so long, for like a month or so, on patients in coma, for example, and just sleeping on the bed, will develop this tendency to form, or basically they are at higher risk of thrombosis because their blood is not flowing. They are not walking around. They are not moving. Their blood is stasis in their. It's just there. It's not flowing in their body. It's staying there. And remember, blood that is not flowing in the body, in the vessels, carries high risk of thrombosis. Tissue injury, because any tissue injury tissue injury such due to surgery, or fracture, or burn, carries high risk of thrombosis, because any tissue injury secretes tissue factor, which activates extrinsic pathway factor 7, and so on. And cancer for the same reason. I think that's it. I hope you understood it well. Yeah, one last thing. If someone, you see this is varicose striae, where if a patient presents with one of them, he has two. If the patient presents with two of them, yes, I wrote it here. He increases his chances of developing a clot by 50 to 60%. And if a patient presents with all three, a patient has an abnormal blood flow, has a hypercoagulable state for any genetic deficiency, inherited or any other reason, has an endothelial injury, increases his risk of thrombosis to up to 90%. Yeah, that's it. I think this is the last thing I had to say. Thank you very much for your time. I hope I explained it well. And again, I want to tell you, please don't hesitate to contact me. I have my contact information at the very beginning in the first slide. I hope I made it easy. Inshallah, you got this. HLS will be the last exam in the exam marathon, I call. And best of luck. I wish you best of luck in your coming exams. Thank you very much.